Oh, yeah, recording in progress.
Okay, great. Okay, welcome to the first in a series of webcasts that AMEND will be producing over the coming months, looking at a wide variety of topics of interest. And today I'm delighted to introduce Professor Karim Meeran, who will be discussing corticosteroids, a class of medicines that we receive many queries about from our patient communities. So Professor Meeran is a professor of endocrinology at Charing Cross Hospital in London, as well as the Deputy Director of Medical Education and lead clinician for endocrinology at Imperial College in London. He qualified at the Royal Free Hospital, then trained in endocrinology at Hammersmith Hospital and St Bart's Hospitals. I'm also pleased to say that Professor Meeran has been a trustee of AMEND for many years now, as well as a volunteer at many of our annual patient information days. So welcome.
Thank you very much for a very kind introduction.
So we're going to talk about corticosteroids, and the best place to start, I guess, would be if you could give us a quick overview of corticosteroids and why they may be prescribed in patients generally, as well as for those with the endocrine conditions that AMEND supports.
Okay, so corticosteroids, the word cortico comes from cortex, which is the adrenal cortex. And the adrenal cortex makes the hormone cortisol, which is a natural human corticosteroid that we all need to survive. And it's very carefully controlled by the pituitary gland, and the level of cortisol in your body depends on time of day. So it seems to be very important in informing all your cells about what time of day it is, and basically makes them all go in sync, in synchrony, and it sort of drives what people call clock genes. So all your cells know that it's time to wake up or time to not be awake. So that's what normally happens. Now, it was discovered in about 1940-ish that if you take adrenal extracts and concentrate up what we now know is cortisol, it has a very good anti-inflammatory effect on people with inflammation. So, for example, asthma or colitis or any of those autoimmune diseases, if you give a huge dose of adrenal extract or steroids, as people call them, you can treat those conditions that have in the past been life-threatening. So using extra steroids or glucocorticoids saves lives, especially in conditions like asthma and so on. So there's two separate uses that we now have in 2024. One is if you have no adrenal glands, you need some hydrocortisone or an analog of a steroid to survive. But also, if you have a condition like acute severe asthma, we can give you a short course of very high dose glucocorticoids or steroids, which will treat the asthma and keep you alive. So they're the two main roles of these steroids.
Okay, that's lovely. Thank you very much. So historically, hydrocortisone has been the go-to corticosteroid, while prednisolone has had something of a bad reputation in the past. As far as I can tell now, this is changing. So can you explain how this change is coming about?
Yeah. So hydrocortisone is cortisol. Okay. In fact, I can show you if I can share my screen, the molecular structure. I know this sounds a bit bopping-y. So on the left is a molecule of cortisol, and it's a it's a steroid structure. So those four rings is what makes it called a steroid. Okay. And if you look at hydrocortisone, it's got various random bonds in it. On the right-hand side is an artificial version of that made in laboratories in the 1940s. And the only difference between that and hydrocortisone is that double bond there. Okay, so this was one of the first manufactured steroids, and this is before we understood the molecular structure. But now we know that prednisolone is the same as hydrocortisone, except that it's got a double bond here. Now, what that double bond does is make it slightly different. And what that means is it's a bit stronger, it's a bit more potent, so we need fewer milligrams to give the same effect. And best of all, it lasts longer. And so instead of taking hydrocortisone more than once a day, you can take prednisolone once daily. So there's a number of advantages to this because when you measure the level of prednisolone, if you measure the level of cortisol in a person who's got adrenal glands, it goes up in the morning, it goes up just before you wake up, and then the adrenal glands keep on making cortisol, but less and less through the day. The level slowly falls over time. Now, if you take a hydrocortisone tablet, it's not like an adrenal gland because you have the whole thing in one big blast, and then it's consumed, it's all gone by about 11 a.m., and you've got none left at all. So you're forced to take hydrocortisone 2 or 3 times daily in order to have enough to have a good quality life. If you take prednisolone, you can take a much smaller dose, say 3 milligrams of prednisolone, it's more potent, and it lasts for the whole day, and level finally disappears in the evening when it should be low. And that really tells your body what time of day. So if you take it in the morning, that's the clock saying it's now time to wake up in the morning. So we advise people to take whichever drug first thing in the morning for their first dose. And the problem is, if you're on hydrocortisone, you need a second and a third dose. And so the timing of that can be difficult. And also, we tend to use a little bit too much. It's very hard to get exactly the right dose of hydrocortisone. We need it more than once a day. So that's the basic difference between them.
Okay, brilliant. Thank you. So now you've been working on a research study sort of comparing hydrocortisone and prednisolone for several years now, haven't you? So I just wondered whether you could sort of give us a little bit of an overview and then an update really on how that's going.
I mean, my interest started in about 2014 when we were looking at these two molecules, and some patients were saying, well, hydrocortisone is very inconvenient to take. I'd like to take it. I can't remember to take 2 or 3 doses. So that was the first problem. And the second problem that we had was the cost of hydrocortisone for some reason rose astronomically. And so we then started looking at alternatives. And then we discovered that prednisolone is more convenient, but then we made an assay for prednisolone and discovered that the levels, this was about 2016, the levels were very similar to normal healthy people of steroid. And so we worked out that, in fact, if you take prednisolone once daily, you actually get a closer mimic of a normal circadian rhythm than hydrocortisone. The minute you take a second dose, you're going to overshoot. So what we then did, because everyone said, oh, well, the hydrocortisone is a natural thing, and we always use hydrocortisone. And in fact, I was taught as a junior doctor to use hydrocortisone because it is the same as cortisol, and prednisolone is artificial. But of course, we're now finding that artificial drugs have got benefits. And we use artificial drugs for many things, like insulin, for example. We use analogs of insulin now because they're better. They're better because they're more convenient. Same with steroids. If you can modify it to make it more convenient, but get the shape of that curve, the level in the blood be the same as a healthy volunteer, that will be better. So in order to decide whether that I'm right, we have to do a proper trial. We can't just say, well, it looks right. So what we have done is we've asked a large number of people. In fact, with AMEND's help, we've got healthy people who are healthy except they've got no adrenal glands, and therefore they needed hydrocortisone. And they've been on hydrocortisone for many years and they've been quite well. And we said, let's do a trial of between 4 and 6 months of prednisolone, and let's measure everything like your blood sugar, your blood pressure, your bone turnover, because one of the problems with too much steroid is that if you have too much steroid, you become hypertensive, you might become diabetic or have a higher glucose, you might have a higher cholesterol, and you might have osteoporosis in the long run. Now, these are all long run things. So you don't tend to notice a difference on a day-to-day basis. But if you want to prevent trouble in the future, we need to know which one's better. So we've got a large number of people. And in fact, we're just finishing the last patient at the moment who's taken part in the study. And we're measuring prednisolone levels, but also measuring their bone turnover, their blood sugar, their blood pressure, and other things to see which one is better. And I don't know the answer because all of them are blinded. In other words, neither I nor the patient knows whether they're on hydrocortisone or prednisolone. Now, you might ask, how are we doing this? And we're doing this because the hydrocortisone is typically 10 in the morning, 5 at lunchtime, and 5 at 4 p.m. And in the second half of the study, we're giving them the same number of tablets, a single prednisolone tablet of 3 milligrams, and then 2 placebo tablets. So that means I don't know whether on the prednisolone and placebo or the hydrocortisone. And that's to avoid the bias of the advantage saying, well, I like this because it's once daily. So we're making it equally inconvenient and looking at how people feel and lots of other things, and to see what happens to all these other markers. And we'll know this probably another 2 or 3 months. So by the summer of 2024, we will have some answers and hope to publish a paper saying which one is better. At the moment, I can't tell you which one is better. I will say that we have got some other studies that have been ongoing, which is not blind, and patients know what they're on. And it seems that they're reporting that when they're on prednisolone, they find it easier to keep the weight under control. They find it easier to keep the blood sugar under control. And so my thought is that we're going to probably find that prednisolone is better, but let's wait till the results come out before we can really say that.
Yeah, it's very exciting. I can't wait to find out what the results
I
are.
can't either.
As a prednisolone taking patient myself, I know which one I prefer, but I'm not going to say that either. So, something that patients do ask us a lot about when they have adrenal insufficiency is what are the differences in the 6-day rules between hydrocortisone and prednisolone? Because obviously you've got possibly a triple daily dose of hydrocortisone, but you generally only have a one tablet a day with prednisolone. So what are the differences there when you've perhaps got diarrhea and vomiting?
Yeah. So obviously, if you get diarrhea and vomiting, then neither oral drug will be any use. If you're vomiting, then nothing will work. Neither oral hydrocortisone nor prednisolone works. You need an injection of hydrocortisone. Okay. And that has always been the case. So if you are very sick and you get something like norovirus and you're vomiting, you need your steroids to survive. And so you need to have an injection of hydrocortisone, ideally at home. But if not, if you've not got it available, you just get to casualty and tell people you've got adrenal failure, and they will give you some hydrocortisone and keep you alive. If you don't have quite such an illness and you're keeping things down, when you become sick, your body needs more steroid. Okay, so when I become sick, if I get pneumonia, my adrenal glands double their output of cortisol, and that's been shown. If I have an operation, my adrenal glands tend to increase their output of hydrocortisone or cortisol. So we want to mimic that. And so in the case of both drugs, you will double the dose for 3 days. Now, I say 3 days, it depends on how long the illness lasts, but the typical serious illness tends to cause a rise for 3 days. So typically, we say for both drugs, double your hydrocortisone or double your prednisolone for 3 days. But if you're unable to keep it down, you need an injection. I can't get away from that. Okay, that applies to both drugs. So in effect, they're both the same. You simply double your drug for 3 days. I know some people have said triple, and if you're very sick, that might be appropriate. But as soon as you're thinking of tripling, you're really unwell, you might be thinking about going to casualty, to be honest with you, rather than struggling on at home. I think that's a mistake.
Yeah, yeah. Lovely, thank you. Now we're talking about hydrocortisone and prednisolone, but are there any other steroid medicines available in the UK at the moment with similar ilk?
Yeah, there are. And I should be careful not to confuse people. So the word steroid is obviously means any molecule that looks like that four circles. Okay, and that basically is the structure of cholesterol. So all steroids come from cholesterol. So I think what you mean is, are there any other similar glucocorticoids, that class of steroid? Because just to be clear, testosterone and estrogen are also steroids, and of course they're also abused by other people in different ways. So when you say steroid, we don't mean those ones. Those are the anabolic steroids that people use. We're talking about glucocorticoids, and we've talked now about hydrocortisone and prednisolone. The other one that many of you will know since COVID is dexamethasone. Now, dexamethasone is a very, very potent, excellent steroid if you need a really, really large dose. And the evidence came out about 4 months after COVID was causing so much trauma in the world that dexamethasone, a very, very large dose of glucocorticoid, saved lives. So people who were dying of inflammatory lung problems were saved by having a huge dose. And so the dose was dexamethasone 6 milligrams. Okay, now that's it. Now dexamethasone is 7 times more potent than prednisolone, and prednisolone is 7 times more than hydrocortisone. So 6 of dex is like 40 of prednisolone. It's an enormous dose, but that's what you need when you've got COVID. You need to suppress your immune system so that the inflammation doesn't cause lung failure, and it works. So we also use dexamethasone for patients who are very unlucky and have large brain tumors, where you want to really suppress any edema around the brain. So there is a much more potent steroid around, and that's dexamethasone. I would not advise the use of dexamethasone as a replacement. It's so potent and so long lasting that even the smallest dose available of about 0.1 milligrams tends to cause some Cushingoid effects over time because they've got a very, very long half-life, like 2 days. So I guess you could argue you have it every other day, but the levels are very, very high in terms of the outcome. So use it appropriately. All of these drugs have got really good uses, and in the long run, they'll have side effects, of course. Now, if you want to save your life, there's no question you should take your dexamethasone for the 10-day period as you've proven to save lives.
Okay, brilliant. Thank you. So given that we have a couple of corticosteroids there, what might be the reasons that a patient is moved from one steroid medication to another?
That's a good question. I mean, traditionally, I have always started patients on hydrocortisone, and now I always start them on prednisolone because A, it's more convenient. B, I think the evidence is about to come out that it's actually better for their metabolism. But there might be some patients who metabolize the drug very slowly. And so, for example, because we have, as an experimental research tool, we can measure levels of prednisolone. We have 1 or 2 patients who seem to need only 1 milligram of prednisolone, which is a bit peculiar. And then we measure their levels, and it seems that they break it down really slowly. And some of those patients are just on hydrocortisone 5 milligrams once a day, because for them, so we're all different. The way we metabolize drugs is different. There's a very small number of people very slow metabolizers, and then there are others. I've got one patient who's a very, very fast metabolizer, and he couldn't keep up. He was on hydrocortisone with Addison's disease, adrenal failure, no adrenals that worked, and his cortisol levels were always 0. And he took his hydrocortisone and felt a bit better, but he was on enormous doses. And then we switched him to prednisolone, and I kept having to clock the dose up. And he's now happy and well on 12 milligrams once a day, and his levels are the same as anyone else on pred. So it's unusual. Most patients need 3. Some patients need 4, and very few people need more than 5. And then there's one guy who's on 12. So that's a very unusual anomaly, but it's important to bear in mind that we metabolize drugs differently. So that might be why you want to change the drug. And then the other thing is, obviously, it depends on how patients feel, what they're comfortable with. If patients want to have more levels later on in the day, it might be they'll find hydrocortisone better. I haven't had evidence of that, but I'm certainly open to letting patients choose the drug that they feel better on. So I think that is an important difference. If we find in an individual that the blood levels are harmful, we can inform them. But if they say I actually feel better on one than the other, then that's an important finding.
Yeah. And looking at it the other way, are there any reasons why a patient wouldn't be prescribed a particular corticosteroid?
I can't think of a reason why. I mean, they need one. They need to have. If you've got no adrenal glands, without any steroid, you will not survive. So you need one or the other. So they're the two that are available in the UK. In other countries, there are analogs, different analogs. There's cortisone acetate in some countries, and that's just another modified molecule of cortisol. They all seem to work very similarly, and until now, we've not found any evidence of difference. So if they're all the same, you could choose any one you like. If we find that one is better than the other, then we might encourage people, explain to them that we're finding these differences and you might prefer one over the other. At the moment, I can't think of any reason why any is contraindicated. I think that you must have one if you need it.
As long as you're on the right dose, then
I think dose is very important. You're quite right. And just to summarize the issue that you highlighted there. So if you have insufficient steroid, then you feel it. You feel underregulated, you feel unwell. If you have a normal or too much, you feel great. And the problem is, if you feel great on too much, then the downside in the long run is you become slightly hyperglycemic or diabetic, you become a bit hypertensive, and you become a little bit osteoporotic. And in years to come, if you get a fracture, you'll think that was a mistake. But of course, you don't know that's going to happen to you. And so I'm very keen that everybody does their best to take as little as possible without feeling ill. Okay. I'm not saying you need to underrun. You just need to keep it stable.
Yeah, brilliant. Okay. And finally, I wanted to ask, what do you see as the future for corticosteroid replacement in patients with adrenal insufficiency? Are we all going to be connected to pumps, or are we going to stick on tablets, or is there something else?
It's a really good question. So I mean, pumps have got pros and cons. I mean, pumps are very difficult. So you got to carry it with you all the time. I mean, we use pumps now in diabetes, and I will say in diabetes, pumps have transformed lives, but they were on 3 or 4 injections a day to mimic that. The big advantage of steroids over insulin is that steroids can be taken by mouth because they're absorbed, whereas insulin, which is a protein, can't be. If you take insulin by mouth, your stomach acid will destroy it. So we're stuck with injections, which is why pumps work for them. Certainly, there are trials going on to see whether giving pulses of hydrocortisone, which is even more natural than what we're doing, is better. And if we find that they're better, then that might be the future. That will need to be balanced with the inconvenience of setting up your pump every morning, which is what the diabetes patients have to do. I mean, they have to do that. In the case of diabetes, the patients are very clear. They are much happier and much better on a pump. And so they find the time every morning invested in setting it up is worth it for the rest of the day. Whereas otherwise, they're on 3 or 4 injections a day, which seem to draw up. Whereas that doesn't happen for people who are on prednisolone. One tablet in the morning, and then that's it. So it needs to be as convenient as that, probably. So I think we'll be either on prednisolone or hydrocortisone tablets. I think there might be some patients who would like to try a pump and might have some benefit from it. For example, if they can't absorb it well. But I think in general, we're going to stick to oral, and working out the best one is going to be the future, I think. There is one other steroid that I haven't mentioned, in fact, that I should have, and that is delayed release hydrocortisone, which you take the night before. That is looking like it might have some advantages in that you get a rise in cortisol in the early hours. Now, I think the timing isn't perfect, so they need to do a bit more work with that. But I mean, one option I'm thinking about is whether we use that technology with prednisolone and have delayed release prednisolone, which you take last thing at night, and then at 5 a.m. it releases. That would be really perfect once daily treatment. But that's pie in the sky at the moment. But it's something to think about.
Yeah, yeah, definitely. Or you wake up in the morning and pop your tablets, but I suppose it depends what you're doing. So yeah.
It does. It does.
Brilliant. Okay. So thank you so much for that and for giving up your valuable time to
That's quite all right.
discuss all things corticosteroids today. And I think that actually the answers to those questions, which are quite often asked to us, will definitely do a bit of myth busting and a bit more information for patients. So very grateful for you giving up your time. Thank you very much.
Not at all. Thank you for having us.